and welcome to tonight's StreetVet Skill Set CPD session. Thank you very much for joining us. We really appreciate it. My name's Pauline Miller. I'm the volunteering officer at StreetVet, and we are joined by a huge friend of StreetVet, Ian Battersby, who's been a long-serving member of the Specialist Advisory Board and is here this evening to talk to us about the new guidelines for prescribing antibiotics at StreetVet. So over to you, Ian.
Cool. Thank you very much. So hello everybody. This evening's the format's changed slightly because it was meant to be me and Jade kind of having a conversation and then getting you guys to contribute into the discussion. But with Jade not being able to make it at the last minute, I've put a few slides together just to give it a little bit of a framework. And then hopefully in the second half of the session, we can get some discussions going because this prescribing policy, has been drafted up to a certain point, but this is, an important phase where you guys give feedback and input onto any adaptations and any requirements that you feel need to be in there. So I just realized I need to share my screen, don't I? There we go. And then share. So can everybody see that okay? Everybody's turned the camera off, so I can't get any hands up. Oh,
Yeah,
there
we
we
can
go. There's one.
we can
There's one
see.
with the camera
Yeah.
off. There's a smile, so it's there. Right. Oh, so the development of these guidelines so far, just to give you a little bit of a background of the timeline, around October, November last year, Jade asked me to look at developing antibiotic prescribing policy for StreetVet. And to give you some background as to why she asked me, I'm an internal medicine specialist. I've been interested in One Health for a long period of time, and in 2012, I developed the original BSAVA Protect guidelines. So I've always been pushing, promoting responsible antibiotic use, and the last 3 years, I've actually finished that contract now. I finished 3 years as a global pharmaceutical stewardship lead for Mars Veterinary Health, where I was developing antibiotic prescribing schemes in America, Asia, and across different parts of Europe. So that's why she asked me to get involved. So I did an initial draft using some of the international guidelines that are independently developed. So some of them are listed here. So BSAVA Protect, which I'm sure you'll be familiar with. There's the ENOVAT guidelines, which are an European group. International Society of Companion Animal Infectious Disease guidelines, and then the University of Guelph, Scott Wees, who some of you may have heard of. I've worked with him a couple of times. He's developed an online app as well, and I've given inputs into that, so I use that as a resource as well. Now, as an internal medic, I couldn't cover everything, so I'm sure you all know Sue Patterson. She gave input into and refinement into the dermatology sections. And then from an ophthalmology point of view, I'll completely hold my hands up that that's an area that I don't know much about. So I contacted Rachel and Agatha, who I used to work with at Davies Veterinary Specialists, who run the ophthalmology team there. And they were kind enough to input in the ophthalmology part. The guidelines then went to the clinical board. They had a look at them and reviewed them. And then I understand that Jade has then sent the guidelines out to you guys as a pre-read for this meeting so that you can have a read, have a look at what, in your own leisure to kind of get up to speed on them. And then this meeting really is the next step, which is where we get your input and your insights into, there's guidelines that we've developed, but we need to make sure that they're practical and they're realistic for what you're able to do in real life situations. So before we go through the kind of sections of the guidelines and get your input, first of all, I just thought I'd review what pharmaceutical stewardship is as a concept. Essentially, this is optimizing our prescribing for the patient and not only in trying to make sure we get the drugs prescribed optimally for treatment, but also minimizing negative impacts. Ooh. So there's a few definitions of pharmaceutical stewardship. that are out there. This is a little bit repetitive, but it's my favorite one because it's pretty simple. So essentially, it's using the right drug for the right patient at the right time with the right dose. It's a little bit repetitive, via the right route, and importantly, causing the least harm to the patient and future patients. And that statement has two sections really. But we'll break that down in a moment. But I just wanted to give you some examples of some pharmaceutical stewardship initiatives in the human field. Oops, sorry, I realised that's a bit. These were all very last minute put together, so I apologise, they're a little bit rough. So antibiotic stewardship is probably the most common, stewardship protocols that we're all familiar with, and obviously that's aimed at reducing antimicrobial resistance. But in the human field, there's very well established stewardship in other drug groups, such as opioid analgesics, preventing excessive use and inappropriate opioid prescribing, trying to minimize addiction and minimize side effects. There's programs well established on anticoagulant stewardship. So these are, for patients that are on long-term anticoagulants, and that's using a combination of drug stewardship, but also diagnostic stewardship to make sure that patients are not under or over prescribed these medications. And then the psychotropic stewardship programs. So this is where there's been programs to reduce inappropriate prescribing of antidepressants and reviewing when they're prescribed and trying to de-prescribe those drugs and using non-pharmaceutical methods to try to replace them. So there, we often in the veterinary, antibiotic stewardship's the main thing that we focus on, but actually we can apply these principles to all the different drugs that we use. So breaking down this statement, the right drug, the right patient, and the right time, that essentially is focusing on making sure you get optimal outcome for the patient. And I think that's something, I've been talking about antibiotic stewardship for a long time now, and I think everybody, understandably gets fixed on, oh, you shouldn't use it because of AMR, but actually there's an important point of stewardship, and that's making sure when you use the drugs, you use them effectively so that the patient gets a good outcome. And actually, if you use the drugs optimally, get a good outcome, the patient will get better quicker, and then you'll use less antibiotics overall, using that as an example. Causing the least harm to the patient and future patients. Well, if we break down that statement a little bit more, obviously, with any drug, there's potential side effects that can be in the acute moment, the kind of peracute situation, or there can be long-term health effects to the patient if you're using a chronic pharmaceutical. And then, of course, what's increasingly becoming prevalent in understanding now is the impact drugs can have on the environment. There's the impact of drugs because a lot of the ones that we use are biologically active and they end up in our soil and our rivers and things like that. And parasiticides are an obvious example. But pharmaceuticals actually contribute to probably the largest part of a hospital or a veterinary practice's carbon footprint. So that's because of the manufacturing process, the transport, the refrigeration. And so if you're using pharmaceuticals excessively, then you're unnecessarily generating waste and carbon production. And there's very few drugs that have had accurate mapping of the kind of impact on the environment. But one of them is a vancomycin antibiotic, which is not a drug we should be using anyway in veterinary species. But to produce 1 kilo of vancomycin antibiotic, you need around 500 kilos of resources, and you produce around about 50 kilos of carbon dioxide, if I remember correctly, which is the equivalent of flying from the UK to Mallorca. So, if we're able to reduce the unnecessary use of these drugs, we can benefit by reducing side effects. We can also reduce directly and indirectly impacts on the environment. And again, these principles aren't just for antibiotics, they are appropriate for any pharmaceutical. But if we insert antimicrobials into this definition, obviously, we want the antimicrobial to work effectively so that we get a resolution of an infection that's established. And one of the things that I talked about in the last talk is, it's very easy for us to slip into the misperception that antimicrobials take over the job of the immune system. They don't. The An infection is where the immune system has overwhelmed, an infection has overwhelmed the immune system. We use antibiotics to assist the immune system to get it back under control. So the top half of the statement, using these antimicrobials to resolve infection. The second half is, to reduce harm to patients and future patients. So when we talk about side effects, there are some very well established side effects that we recognize, potentiated sulfonamides and things like that in certain drugs. But from my perspective, I actually think, and you will have seen that in the document that I wrote, I think some of the side effects to antibiotics are underreported or underrecognized in veterinary species. If you look at the literature in the human sector, 40% of admissions to A&E departments over a weekend are due to newly prescribed pharmaceuticals, and the side effects from those pharmaceuticals. And about half of those pharmaceuticals are antibiotics. Some of those are GI signs that I worry that we attribute to other disease processes in our patients, but also some of those side effects are things that we can't diagnose in our patients, like nausea and things like that. From a long-term health effect, well, the microbiome, everybody's now increasingly understanding the importance of that, and so by using an antimicrobial, we impact on the microbiome. I've already touched on the potential impacts on the environment of unnecessary courses of antibiotics, and you've got to think about this impact collectively. If all of us reduced unnecessary antibiotic use by 10%, that would collectively reduce the burden on the environment quite a lot, rather than it's a little bit like recycling. And then, of course, when it comes to antimicrobials, the unique thing for the antimicrobial stewardship is obviously we want to maintain these drugs being effective, not only for these patients, but future patients, by minimizing the selection of drug-resistant bacteria. Now, when we look at stewardship policies, they can broadly be put into three groups. So you've got restrictive stewardship, and this is where you use rules to basically mandate that certain drugs must be used in a certain way or certain drugs mustn't be used. And that's common now in a lot of human hospitals, where they'll have certain rules in place for certain medications because they are literally the last tier. Enablement is probably the more common form of stewardship that we use in veterinary practice, where we're using education, we're auditing use and giving feedback to the prescribers, comparing the use of antibiotics between different hospitals to show where there's potential learnings. So it's essentially providing information and education to enable prescribers to make that decision themselves. And then finally, there's the structural element of stewardship. So this is, making sure that there's the infrastructure there so that these prescribing guidelines can be followed. So that in a hospital setting, that may be, access to decision support systems, or, if you want to do certain diagnostic tests to confirm an infection is present, the clinicians have to have access to them that's in a reasonable period of time to be able to execute and make the clinical prescribing decision. So what we were planning for this evening is essentially to get your collective feedback on the working document draft that we've got so far, that's made it, gone through all those processes. We're interested in knowing if you've got any concerns, whether you think some of the, whether it's realistic and practical. Are there additional measures that could help in following these guidelines? That's touching on structural stewardship. Are there other resources that you would need to follow these guidelines? Are there conditions within the guidelines that we haven't covered and you feel that we should have a prescribing policy on? And what we were going to do with me and Jade was just essentially talk through each of the different sections. So, I've got a series of slides to give some structure to the different sections of the document. And then I thought we could just have if people feel comfortable raising their hand, putting in the chat. I'm not sure I can see the chat.
I can see the chat, Ian, and I can read things out if you can't see it. Steph's
Yeah.
already asked where was this document shared? I haven't seen it. I don't have the answer to that, but I can find out if you don't know, Ian.
No, Jade was going to do it. So, and I checked with her last week. So maybe we should do a quick poll then on everybody who's here. Who's seen the document and who hasn't? Oh, there's one. Oh,
So he hasn't seen it. Right, this might be a
that could be it. Well,
yeah.
we can
This
change. We'll change again. So,
I could share if I have I got it, Ian. Sorry, I'm asking you a lot. I'm asking
well,
a lot of you here, but if I've got it, I can share it on the chat.
it's a bit of
Um,
it's a bit of a big document. It's about 13 pages, so it's not one that we could
okay,
kind of get everybody to read as we're going along. But what we can
okay.
do, if let's see if I can get the chat. Oh, hang on. Somebody
Oh,
has.
it's in the.
Yeah, there
It's
we
some
go.
people have seen it. Louise has seen it.
Yeah, I looked in the volunteer. Steph says I've looked in the volunteer portal and stuff. No. So generally, we are at.
It might be something I was supposed to have shared, so apologies if it
Cool. We've
is.
got one yes and everybody else is no. So that's all right. We can work with that. Um, what we'll do then is I've got some slides that just kind of give the high level kind of summaries from each section, and I can go through them. And at the end of each slide, we can, if you want to raise your hand and have a chat, raise a concern, or if you want to pop it in the chat because I can see it now on my computer, I can answer your questions in that way. So the document's about. I'll hold it up. It's a nice Word document that you'll get a copy of. And as
Oh,
people,
thanks, Louise. Sorry to interrupt. Louise is just adding a bit of detail. Like it was shared on an email, but might have just been to team leads. So if your team lead
oh,
hasn't disseminated it, that might be why some people in some locations haven't seen it. Thanks,
okay,
Louise.
okay, no problem. So we'll work with the situation. It's great you're here, and to be honest, I'm sure you'll be able to give it input and structure on to what I'm highlighting this evening. So the first thing is that the guidance sets some core principles. And the important thing to say is that the guidance of the document is considered guidance and not, not absolute. And StreetVet recognizes that these kind of principles will need adapting in certain real life situations. This is something that we're aiming to kind of follow. So I'm sure you're all familiar with a lot of the principles of stewardship with antimicrobials. But just to quickly run through them, the core principles are that we want to only use antimicrobials when they're indicated, not just in case. When we're prescribing empirically, so prescribing without a culture and sensitivity to guide our prescribing, we'll follow recognised guidelines to optimise the choice. And if guidelines are not available, then drug choices will be based on the likely bacteria involved and also the drug spectrum and the pharmacokinetics of the drugs. And I'm on the specialist advisory board. So if you're not sure about an antibiotic selection, you're very well, that's being going to be empirical or based on culture and sensitivity, you're very welcome to ping me an email. Just keep an eye on the chat. Whenever possible, we want to try and confirm that a bacterial infection is possible, is present, but I appreciate that might not be applicable in every street vet situation. We're going to aim to start with lower tier antimicrobials before considering higher tier antimicrobials. And when we prescribe antimicrobials, we're going to avoid unnecessarily long courses because actually it's the long duration of courses that really select for antimicrobial resistance. So whenever possible, we're going to use other therapies to shorten those courses. And when also, in addition to that, another powerful way of minimizing the selection of antimicrobial resistance is using topical treatments rather than systemics whenever ever possible. Now, within the document, it sets out that there is the principles of reserving some antibiotics only for human use. And to be honest, these drugs are very rarely prescribed in the UK for veterinary species, so I don't think it would be an issue at all. It's like using the carbapenems and things. And for your interest, The drugs that are listed in the document that we advise for human, we're going to follow for human use only. Vets in the EU can no longer prescribe. It's against the law. They're not allowed to do it at all. That's how they're trying to protect these drugs. Now, below that tier, there's the high priority, critically important antibiotics, which sit in a European grading system as EMA Group B. And for us, as companion animal veterinarians, primarily the drugs in that group that we're going to be interested in are the fluoroquinolones and the third generation cephalosporins. So in the UK, that will be cefavecin, the long-acting third generation cephalosporin. Now, when we consider using these drugs, we're going to primarily focus on only using these drugs when there is a culture saying that they're the only drugs that are suitable to be used because of resistance, because we want to hold them back from being used excessively. We may use them in an emergency situation, such as sepsis, or if we're going to use them empirically, it's when the pharmacokinetics dictate that they are the only choice really that should be used. And when you consider the pharmacokinetic situation, essentially that's focusing on the fluoroquinolones because they're very lipophilic. You really need to use them in situations such as prostatitis or pyelonephritis, where you've got a tissue barrier that you need to penetrate. So that's pretty much the only exception where I would consider using a fluoroquinolone empirically because of the pharmacokinetics issue. So, as I've just gone through 2 slides, has anybody got any questions or concerns about those principles in a street vet kind of document policy? There's nothing on the chat, no hands, so everybody's good, everybody's on board. That's fantastic. So there is a section in the document on side effects, and I've already touched on it a little bit in the earlier slides. My perception is that we probably under-recognize antibiotic side effects. We've got the recognized ones, the KCS and things like that, but there's a really nice study in some dogs that were healthy that were prescribed metronidazole, or I think it was, I can't remember which one it was. It was a fluoroquinolone, and they tracked them for, I think it was 2 to 3 weeks. And it was a group of like 30 dogs or something like that. Apologies, I can't quite remember all the details. But throughout that study period, it was around 60% developed a reduced appetite, around 70% had a vomiting episode, and all of them had some form of diarrhea in that 2-week period. So these were healthy animals that were put on the antibiotics, to evaluate the impact on their clinical status. And when I read that study, I kind of reflected that maybe there are some situations where I've prescribed antibiotics and I've attributed, the potentially GI side effects to that drug, to the primary disease that I'm treating, rather than actually being to the drug. So really, when we're reducing unnecessary antibiotic use and reducing unnecessary systemic antibiotic use, it's not just an AMR situation, it's also trying to minimize any unnecessary side effects in our patients. So the first section of document is GI. So this hopefully will be relatively straightforward. So from a GI point of view, the recommendations and the guidelines, which again are backed up by the evidence, and the guidelines that we've got. So antibiotics are not indicated in acute vomiting or chronic vomiting. In acute diarrhea, there is now a large document that's been produced by the Innovet group. It's pretty much the best evidence base we've got for a clinical prescribing situation, because it's pulling on 6 or 7 studies, and all of those studies show that there is no benefit to using antimicrobials in acute diarrhea, and that includes when there's the presence of blood. So the guideline, there's a link in the document to the systematic review, But the only indication for using antibiotics in acute diarrhea situations is where there's severe systemic involvement. So you may have a patient that's got a neutropenia or a severe neutrophilia. Um, and when you manage an acute diarrhea patient, if you fluid resuscitate them and they're still struggling, that's obviously a sign that there may be systemic inflammation as well. So for the majority of acute diarrhea patients, antibiotics are not indicated. Carrying on the diarrhea theme, chronic diarrhea. Um, Again, and there was a period of time where we'd advocate using, chronic oxytetracyclines, tylosin or metronidazole in some of these chronic enteropathy patients. Well, now, there's an increasing opinion within the specialist gastroenterologist world that actually in a lot of those situations, that's just putting a sticking plaster on the condition, and all of those dogs inevitably relapse. So instead, there's a prescribing cascade where or an algorithm of approaching these cases where initially you may, obviously you want to control scavenging and make sure there's not, because regardless of what you do, if the patient's scavenging and eating things it shouldn't do, no amount of medication is going to resolve that. So, it's essentially working through a treatment for giardia with fenbendazole, then a dietary trial, and then if the dietary trial fails, then moving to measures to manage dysbiosis, which may be probiotics, prebiotics, or some, there's the potential for fecal matter transplants. And then after that, if you've confirmed that it's a chronic enteropathy, we're assuming that there's been diagnostics done in this situation to make sure there's nothing else going on, like an ultrasound and some routine bloods, then glucocorticoids before considering an antibiotic trial. So, that's putting antibiotics right at the end of the list. Obviously, there are a very small number of dogs with ulcerative histiocytic colitis that are directly caused by bacteria, but a lot of the bacterial causes of diarrhea are self-resolving to a point where, in fact, I personally can't remember the last time I did a bacteriology sample for a chronic diarrhea case, because if you get a positive for E. coli, salmonella, or campylobacter, I didn't know what it meant, because you could find those in normal animals. And if they are causing disease, they inevitably self-resolve and they're self-limiting. So in summary, for the gastrointestinal section, acute vomiting, chronic vomiting, no antibiotics indicated. Acute diarrhea, only in patients that require hospitalization and you're concerned for systemic involvement. And then for chronic diarrhea, only at the last treatment point if it's a chronic enteropathy, and you go through a number of other steps. So after that brief summary, welcome to have anybody's comments, suggestions, or disagreements. Is everybody maybe in the chat, if everybody puts a thumbs up if they're happy, because that's better than silence for me, because I don't know what everybody's thinking. Oh, there we go. Happy. Oh, thanks, Steph. Oh, Steph, hello. Haven't seen you for a while. So Steph's happy. Anybody else happy? Yep.
I think quite a few thumbs up went up just then, Ian.
Oh, there we go. It's just my internet's very slow. There we go.
Yeah, you've got a few. You've got a lot.
Brilliant. Right, we'll take that as a pass. Right, so the respiratory system. Essentially, these are the conditions that we've listed in the policy. It's not exhaustive because Jade wanted me to keep it limited to the things that you're realistically going to see or treat on the street. So, infectious canine tracheobronchitis, otherwise known as kennel cough. Guidance now indicates that we shouldn't really be using antibiotics in patients unless the clinical signs have been persisting for over 10 days. In the very rare situations, I've only ever seen one dog develop pneumonia from infectious canine I can't say it, kennel cough. And it's a very, very rare complication. But if the patient isn't improving after 10 to 14 days, then a course of antibiotics, primarily doxycycline, would be indicated. Similarly, for feline upper respiratory tract infections in cats, if they're eating and they're and otherwise happy, then no antibiotics are indicated for the first 10 days. Antibiotics will only be indicated in in those patients if they're systemically unwell and not eating. Canine nasal discharge. If you're presented with a patient with a nasal discharge, a dog, sorry, with nasal discharge, bacteria are not a primary pathogen of the nose in dogs, and therefore it's likely secondary. So certainly there's limited value in taking a culture of the nasal discharge because it won't be related to the primary etiology. And, because it's a secondary infection, if it's persisting, then it really should be looking at further diagnostics. Maybe there's a foreign body or something like that, because ultimately, if you prescribe antibiotics in those cases, you're just treating a secondary consequence. Oh, Anne's written, is ARD or a thing anymore? ARD. I might need some help on that abbreviation.
'Cause you can, if anyone, whoever answers the question
Oh,
wants to
antibiotic
unmute.
responsive diarrhea. Oh, there was
Oh,
two
there you go.
A's. There was two A's. That's why I got confused. Yeah, yeah. So, no, we're very much moving away from antibiotic responsive diarrhea. That's why we've put it right at the end of the treatment algorithm. I was a resident when Ed Hall, developed that theory and stuff, but we very much moved away from that now. The more we've understood about the microbiome. Similarly, one thing I should say as well is that for a long time there was people using metronidazole for immunomodulatory effects in these cases rather than it being for affecting the microbiome. That again is we're not quite sure where that kind of evidence for that comes from. Nobody can find good solid evidence. And to be honest, what I suspect probably was happening in those cases is that you were adjusting the microbiome more than anything. So yeah, antimicrobial resistant responsive diarrhea, that's unfortunately, it's very 20 years ago. But that's the beauty of medicine. I now present guidelines that contradict things I said 10, 15 years ago. And that's because our understanding has improved. So, that's the beauty of medicine. What we recommended 20, 30 years ago might not be best practice. Sometimes it is. It's constantly evolving as our knowledge improves. So, back to the respiratory section that I've just talked about. Is everybody happy with that? If we could have some thumbs up on the chat, that'd be awesome. Hey, Steph, give me a thumbs up on the camera. That's cool. So that's one, and then hopefully, oh yeah, there we go. Cool. Brilliant. So pyoderma next. So this is where, to be honest, there's been the biggest change, and there are WSAVA guidelines now, and there are the ISCAID guidance, and this also is guidance that aligns with the Protect as well. So traditionally, long antibiotic courses have been used in dermatological cases. But they've been really tailored back now, and there's a real push towards moving topicals. And what's interesting when you go back in the literature and things like that, looking at where not just with skin but for other conditions, where the course durations come from, there's very little evidence, both in veterinary and also in humans. And there's a lot of work now in humans kind of looking to do evidence-based trials to reduce the number of antibiotic days in a course. And in fact, if you take it, if you write a lot of antibiotic courses down, you can divide, that are recommended in textbooks, both veterinary and human, you can divide most of them by 7 or 5 because 7 and 5 are nice multiples for patients and owners to remember to follow. So if the Babylonians had made a week, not 7 days, but made it 9 days, would have been prescribing multiples of 9, I suspect. So now with increasing understanding, we're beginning to realize that our previous courses of antibiotics have been excessive in some situations. So the current guidelines, there's three different organizations that are promoting this now. If with pyoderma, if you've got a surface pyoderma, you primarily use topicals, either hydrochloric acid or chlorhexidine in a spray or a foam form. If it's particularly difficult to resolve, then cytology to confirm whether it's bacterial or yeast, and then you can use an appropriate topical therapy. For superficial pyoderma, again, initial treatment would be with topical treatment for the first 2 weeks, and then if no improvement after 2 weeks, confirm that it's bacteriological before considering systemics. And deep pyoderma, again, emphasizing the importance of using topical medications. Now, because of the way chlorhexidine adheres to the epidermis, it's better to use chlorhexidine in deep pyoderma situations. But the prescriptions of systemics in these situations really should be guided by a skin culture. And this is, if you think about, when I graduated, it was minimum 6 weeks for a lot of these deep pyoderma cases. And often when they clinically resolved, you just carry on, even though the skin looked fine. Well, but this is quite a significant reduction. So, could have a massive impact on all of those things I've talked about, just, AMR, but also unnecessary drug prescribing and potential side effects for our patients. So I've only done there's more detail in the document about the different little bits and bobs from Sue on what you can do in these situations. That's very high level, but is everybody generally happy with that? If everybody wants to do some thumbs up. Oh, what about patients that are on steroids for chronic allergies, still short treatment courses? As far as I know, it might be something to confirm with Sue. That's a really good question, Steph. But one of the things that I think is actually, one of the things I should have put on the slides is that if there's a pyoderma, it's secondary to an underlying cause. So, if it's on steroids, you'd still approach it the same way because presumably it wouldn't be very high immunosuppressive dosages. But actually, if it's already on chronic steroids, it needs to stay on them if it's primarily for a dermatological condition, because otherwise it's just going to get worse. So perfect. Yeah. So yeah, if you have a pyoderma situation, particularly a deep pyoderma, the question you've got to ask is why has it happened as well? So really nice question, Steph. That helped me remember. Yeah, chlorhexidine is much more ecotoxic than hydrochlorous. Yeah, absolutely. So, and it's a product I'm not a dermatologist, so I've not really used it, but from what I read about it, it's really gentle. It's like it just seems too perfect to be true. It's not as irritant as chlorhexidine as well. So, it's a great product that we've got there in our armory. So that was lots of thumbs up, which was great, and some questions. So a otitis externa. So if possible in these cases before prescribing antimicrobials, you want to use cytology, but I appreciate that might be challenging on the street. It may be you can take a swab and then take it back to the hospital and look at it. One thing that I mentioned in the last talk, which was on MICs and culture and sensitivity profiles, if you're using topical therapy, culture of ear swabs is really of limited value for guiding your therapeutics, because the breakpoints that are used in the lab are for tissue levels of the antibiotic. If you're using an antibiotic topically, you'll probably reach 10, 20 times the level that it's being tested at against in the lab. So if it's resistant in the lab, you can still use a topical medication and it be effective because you're using a much higher dose topically. So therefore, there's limited value in doing a culture in an otitis externa situation. Now, what's really interesting is that there's been a lot of work in Denmark and a shift really in management of these cases. So it's basically advocating using topical antiseptics, so our friend hydrochlorous again, in addition to using either systemic or topical steroids. And in a lot of cases now, they're finding just by opening up the ear canal, by managing with steroids only, plus an antiseptic, changing the kind of fleur factors and all the different, things that have allowed the infection to establish actually resolves a lot of the otitis cases. In the policy, if the antimicrobials are required, then obviously we're going to try and use them topically rather than systemically because that's better from an antimicrobial stewardship point of view. And then within the guidance, there is also just recommendations if you do cytology. So say if you prescribe steroids to open up the canal and you've still got an issue, then you do a swab and do some cytology. And then you find cockeye, there's some recommendations on drugs to use there. And then if you've got rods, recommendations of drugs to use as long as, again, when thinking about gentamicin, as long as you're happy that the eardrum has not been ruptured. So again, that's a very high level kind of summary of, there's about half a page of text in the policy that you'll be able to read through. Is everybody happy? Got any immediate concerns with that? Anybody want to give some thumbs? Oh, there we go. Cool. Wicked. Right, I shall move on then. So wounds and abscesses, the policy is recommending for if you've got an anal gland infection, in a lot of cases, expression only maybe could be will be effective. In some cases, you may do a flush. Systemic antibiotics are only going to be really useful if you've got a cellulitis around the anal gland abscess. Acute bite wound management, the most important thing really is to lavage the wound, and if it's superficial and localized, then antibiotics are often not indicated. You can just manage it topically. Obviously, with any wound that may be on the abdomen or the thorax, you may need to consider, you might need to investigate in case it's gone deeper into a cavity. And then if you have an infected wound, obviously lavage, debride, and then from an antibiotic course point of view, if you've got good tissue apposition, then in a lot of cases, 3 to 5 days of antibiotics would be all that you need. And within the policy as well, there's different choices of antibiotics, but I'm conscious I need to mention that at the end, I'll just do a little summary of what we're proposing to change with the backpack from an antibiotic point of view. Cutaneous abscesses. I'm sure everybody's now increasingly aware of all the great work on cat bite abscesses where, in the vast majority of cases, they will resolve with lancing only. So antibiotics are only required in those situations if they're systemically unwell or there's presence of cellulitis around the abscess. So if anybody's got any questions, concerns, or if everybody's happy, can give me some thumbs up, that'd be great. Oh, is there any scope for using beads, e.g. PMMA? Oh, I saw them used in wildlife seed and thought the use in the context due to no guarantee second check might be. So I'm presuming these are antibiotic embedded beads. I've only ever used those kind of antibiotic beads in really resistant surgical site infections. So I can't remember how expensive they are, but once they're in those well, in this situation, they'd be in and then they'd never come back, would they? Well, they might need removing. So I would say that it's not certainly something we'd be looking to use empirically or in most situations, but there may be certain situations where that might be the only option. And the premise of the beads are essentially, if you've got a resistant bacteria on the culture and sensitivity profile, by using those beads that locally release the drug, then that's obviously going to reach much higher concentrations than if you give it systemically. So it's pretty much like giving it topically. But nice question, thank you. Systemically unwell include high temperature and being off food. Yes. Good question again, Steph. Right, next one. So, urinary tract. Sorry, this is a bit of a list. I'd have done it a bit more interesting and interactive, but I didn't have much time. So, um, so, from a urinary point of view, we cover FLUTD, which we know the majority of which are not bacterial in origin. So recommendations are to use non-steroidal anti-inflammatory drugs as a pain relief for 3 to 5 days. And if the patient doesn't resolve its clinical signs, then antibiotics may be considered, or you may want to get a culture. Subclinical bacteria is a condition that is well recognized in humans, and we're increasingly recognizing it in dogs and cats. So, for a long time, we've assumed the body is sterile in all of its cavities, but actually, our knowledge now is increasing that it is normal for bacteria to appear in some of our body systems and the body just eliminate it without any clinical signs. So there are studies looking at dogs. I think there was about 100 dogs in one study where they tracked them, and they found around 10–15% of them developed bacteria in the urine. Some of them even got pyorrhea. They didn't have any clinical signs, and the bacteriuria resolved without any treatment. Similarly, in cats, I think it was around 7 or 8% of cats develop this kind of cyclic, kind of asymptomatic bacteria. And it's well established in humans to a point where, if if you've got patients with renal transplants, sometimes they don't even treat bacteria, even though those people are on immunosuppressives. So if you've got a patient where you've got a urinary culture and it's showing no clinical signs, then it may not be clinically significant, and hence you don't need to treat it. And that's something that's really changed from my perspective. I can remember 15, 20 years ago, me doing lectures on Cushing's dogs and saying, oh, you might find bacteria in the urine when you're monitoring and you need to treat it. And same with diabetes. But unless they're showing clinical signs, treatment's not indicated. Canine sporadic cystitis, short courses are now being recommended. It's interesting a lot. We haven't. Fergus Allerton's trying to do a study to evaluate this in more detail, but it's well established now in the human side of things. There was a massive Cochrane review involving like 10,000 patients. It was looking at female women that had an acute cystitis, and they found that 3 days of antibiotics was no different to 12 days of antibiotics. And what was interesting in that is that some of the studies showed that at 5 days, even though some of the women had not got clinical signs of cystitis anymore, some of them still had bacteria in their urine, but it had been sufficient to get the infection under control, and then the immune system finished the job. Recurrent cystitis, well, you don't really want to prescribe empirically in a patient that you've already prescribed antibiotics. Ideally, you'd want to do a culture, but also consider investigations, particularly if it's not a particularly long period of time in between episodes, because you may have a predisposing factor, such as stones or conformational issue, which means that if you prescribe more antibiotics, you're essentially just going to be selecting for a resistant infection. And then the final urinary thing that we cover is prostatitis. Well, obviously you need hormone therapy, but in this situation, you've got to consider the pharmacokinetics. So as I mentioned before, you need something lipophilic. When the prostate is inflamed, most antibiotics will get in there, but as the blood prostate barrier starts to reform, as the infection starts to resolve, then if you don't use a lipophilic antibiotic like a fluoroquinolone, then your antibiotic's not going to get in and finish the job. So is everybody happy? Any questions? Thumbs up on that section. Cool. 3 days would be enough. Oh, sorry, John had a question, but I didn't. 3 days would be enough. It's not always been told for long courses that it doesn't reach the bladder. So when you're so if I think you said, I think John, your question says 3 days would be enough. I wonder whether it wouldn't be enough. Always been told long courses as it wouldn't reach the bladder. Well, if you look at, we're recommending amoxicillin because that's a beta lactam that actually is excreted into the urine. Traditionally, some people would even advocate for urinary infections that you dose amoxicillin after they've urinated because it's so super concentrated in the urine. In fact, the new breakpoints show that breakpoint work show that because beta lactams reach such high concentrations in the urine, you can overcome resistance that from bacteria that you would have come up as resistant in a tissue level breakpoint. So I'm comfortable with that recommendation based on our knowledge so far, but I've not come across somebody saying that a long course would be required because it takes a long time to reach the bladder because most of these drugs are eliminated in the urine. But I'm happy to, have a chat on email or have a chat or call to expand on that if that's easier. But if you've got any, just because I appreciate it's difficult to do that on the chat. I often see patients after they've had cystitis for humans can report signs quickly. Does this change how long courses are needed if the infection is more established? Um, that's a very good question, Steph. Again, that's one of the challenges of extrapolating. But that's why Fergus is trying to do a study to recruit cases. I suppose what I've evolved to in my own antibiotic prescribing is even in most cases now, I rarely prescribe more than 5 days and I now reassess. So, if you're worried that this one's been going on a little while, then 3 to 5 days, go for 5 days and then reassess. That's been my recommendation because you may find it's not needed. Yeah. Cool. Steph's on the you're on fire today with the good questions, Steph. So ophthalmology, apologize that there's some typos in this. It was all done very quickly. So Rachel and Agatha have put down some recommendations, primarily using chloramphenicol for conjunctivitis or cases of corneal ulceration. That's their first choice. From a stewardship point of view, but also has the added advantage that it doesn't need to be refrigerated. So it is something that could potentially be in the backpack. And within the document, again, they give advice on how to assess an eye case and then what to do in certain situations with respect to lubricants that may be of benefit in these cases. So, in corneal ulceration, you may also need to exclude things like KCS. So I'm going to skip over this bit a little bit because despite being sat next to David Gould for 15 years in the Davies office, and he taught me at vet school ophthalmology, I did remind him how little I know about ophthalmology. So I'll just skip. If you've got any questions on the ophthalmology section of the document, you can fire me some questions on email and I can touch base with Rachel and Agatha. The last part of the document covers kind of procedural antibiotic guidelines. So essentially, it's apologies, I didn't have time to finish this last one, but it's essentially making recommendations if you've got clean, contaminated, or infected procedures. So clean surgeries, other than those where there's an implant, there are no real justifications for using perioperative antibiotics and certainly not post-operative. For contaminated and clean contaminated, so that's things like cystotomies, gastrointestinal surgeries, and things like that, 24 hours. So perioperative antibiotics for 24 hours is indicated, but no perioperative. Obviously, if you've got an infected patient that you're managing with surgery, that's a different scenario. You carry on with the antibiotic course and change that based on the cultures of your samples. I also covered dentals because I did a recent study. Admittedly, it was US, so I can't comment whether it's applicable in the UK. But I did a study when I was doing my Mars role, and we looked at 1 million canine dental procedures that had been done in the USA, and it was quite striking that there was different populations of practice where some practices were using very little antibiotics in their dentals, and some were prescribing 2, 3 weeks, sometimes 7 days after a dental. Um, Now, firstly, the first thing to say with dentals is that there's very few indications to use antibiotics in dental procedures. The you know Even if you have a tooth root abscess, if you remove the tooth, the abscess will resolve. The main indications for using antibiotics in dental situations is if you've got cellulitis or you've got osteomyelitis present. There are some, I mean, I was taught them at university. There are dogmas in about using them if there's a heart murmur present and things like that because of the increased risk of endocarditis. If you Again, this is unfortunately we don't have the evidence in veterinary to kind of explore that more. That recommendation came from humans, and then now what you look at the human recommendations is that they've pulled really far back on that kind of antibiotic prescribing. The very few reasons where they'll use antibiotics around dentals, such as heart valve replacements and things like that, which are possible in our patients, but are very, very rarely done. So, from a dental point of view, most patients that have a dental don't need antibiotics unless, like I say, they've got cellulitis or osteomyelitis. So, just to summarize the current plan for the backpack, and it's a shame, because Jade's not here. She's got more of a handle on what's in your backpack and how it was going to evolve. Um, but the first thing is, I know that there's metronidazole in the backpack at the moment, but because the new policy advocates that antibiotics aren't used unless the patient needs hospitalizing and is systemic, has got evidence of neutropenia and things like that, there's no need to have the metronidazole. So that's going to be removed. Looking at all the different combinations of conditions, cephalexin could be used in quite a lot of those situations, and amoxicillin for some of the urinary situations. So we're going to look to because I think amoxiclav. I don't know whether amoxiclav's in your bag at the moment. I think it's cephalexin. But yeah, we're trying to look to use amoxicillin rather than amoxiclav because that's a lower tier drug. That's narrower spectrum, which is good from an AMR point of view. Um, just one of the challenges with amoxicillin is that ironically, it's often twice the price of amoxiclav, just because it's not used as often. The backpacks will also, Jade's looking at reviewing some of the topicals, chloramphenicol will be in there, but also looking to develop, have some shampoos and some foams in there. Foams which don't need water and washing and stuff should be really handy for using in on street situations. What we're planning on doing, and it'll be great to have your feedback on this as well, is that we plan to um, is there a steroid only ear pack in the backpack? That's what we'll try and find. That's certainly on my list that I'm asking Jade for. We're going to produce a little laminated guide, which won't have the whole document in because it's quite a big chunky document, but at least something you've got in your backpack so that you can just get it out and just refresh for certain situations. We'd love your feedback as to whether you think that would be useful. Can you repeat what you said about enterotomies and cystotomies? Yes, no problem. So we extrapolate. I keep saying this, don't I? Because it's just because we have no evidence. There was a big review on it, and there's so little evidence in the surgery, in the antibiotic use in surgery. It's in the veterinary sphere. So we use the same categorization as what they do in humans. So there's clean surgeries, there's clean contaminated, and then there's contaminated surgery. So clean contaminated would be like when you're opening a bladder or a stomach, and and you're happy that there's no contamination. Clean contaminated is where you perform a cystotomy and it's got cystitis and you might get some leakage. So in those situations, you'd lavage and then monitor the patient. But in both those, perioperative antibiotics for 24 hours are indicated. It's just not using post-operative, if that makes sense. Cool. So I've repeated that, and yes, thank you, Ian. Yeah, what we're definitely looking to try and find the steroid only eardrops. Jade's at the moment liaising with lots of different pharmaceutical companies that support StreetVet to try and see if we can create the kind of suite of products that will fulfill this policy, because obviously cost is an issue. But obviously, we wanted to get your thoughts on the policy, get your ideas, see if there's anything else that needed to be added, highlight if you think anything is unrealistic, and then once we've got your thoughts, we can firm it all up and then get a little bit more concrete with the discussions with some of the drug companies. And with that, that's all my slides finished. So there we go. I'll stop sharing. There we go. So from me, the first thing to say is thank you for everybody's understanding on how we've had to modify this evening's presentation, not only once, but twice. Yeah, because Jade was meant to be here, and then it turned out you all hadn't seen, well, most of you hadn't seen the document. Oh, somebody said, good to have some. Oh, thank you. That's very kind. The antiparasitics. Oh, yes, that would be great to do. That could be our next job. Once we sort out the prescribing for this and we get the backpack sorted, then we can certainly have a look at the um, uh, antiparasitics. What about injectable antibiotics versus oral from a compliance point of view, ensuring full course? Um, so I guess there's a couple of things there. There's only one long-acting antibiotic that I guess negates any oral antibiotics afterwards, and that's one the convenient one. As you can imagine, as a person who advocates antibiotic stewardship, not a big fan of that drug because it's a third generation cephalosporin. What's interesting is when you look at the data sheet of that product, it's what's really as an antibiotic geek, this is interesting, but I appreciate it's not something that everybody else would do. Um, Due to different licensing requirements, you can look at different data sheets from different countries and they have to contain different information. And some of the data sheets for Convenia contain information about how long the product stays in the body. And it's primarily because if you have a reaction to Convenia, it's obviously going to stay in the body for a little while. Now, for 98% of the drug to leave the body, it takes 63 days because of the, yeah, 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 yeah. The face, those with the camera ons, the faces says it all. So if you think about it, it's at therapeutic levels for 2 weeks, and then there's 39 days where it's at sub-therapeutic levels in the body. So that's going to be selecting for resistant bugs. But also, I have to admit, I try and avoid long-acting preps because if you do get a problem, you can't take it away. I remember when there was a long-acting non-steroidal that was like once a month tablet. And as a medic, I was like, oh, if there's any vomiting on day two, this is a nightmare because you've got no control. So for me, there's certainly an element of thinking about if there's a problem with long-acting products. The second thing to mention for compliance is that I mean, I guess we often think about cats when we think about compliance, and that's where Convenia's had most of its market. There's been some really nice work done in the States by a lady called Casey Kaiser, and she had these programs where essentially she'd do the consult would have a standard chat about, it's important that we don't use this drug is more convenient, but it's important we don't use it so that it doesn't select for resistance. And most owners were very happy to try pills straight away. The other thing that's really interesting as well is that there's been some nice studies showing where vets will presume that owners want the injectable. They won't even bring up giving tablets. And I can see that. It's completely understandable. You're busy. Most people you assume would want a nice fix, easy solution. Likewise, the same study, what they did was they review, they videoed lots of consults. They interviewed the vets and said, why did you give antibiotics in those situations? and when they weren't indicated, and when they asked the vet said, well, it's because the owner was demanding them, and they interviewed the owner, and the owner's like, I didn't say anything about antibiotics. It was the vet who presumed. So there are worries about things going wrong and defensive prescribing and assumptions that we make when in a consult room, particularly when we're really busy. And I've done that. I'm guilty of that. I can completely reflect that. So from a long-acting injectable point of view or oral, I guess it's all about having a conversation. It's better to use pills if you can because that's you've got more control. You can stop it if there's a problem. You don't have to use an excessively long course like the 63-day. They didn't advertise that bit, did they? That's why that's why it's quite, as an antibiotic geek, that's why it's quite interesting to find that. And then long-acting topical ear drops versus twice a day daily drops, frequently lost, items stolen, used on the street. That's a really good point actually from a practical point of view. And because it's not skin and it's ear, because it's skin, I'm gonna maybe talk to Sue about that. I think that's a really good. See, that's where it's, I hadn't considered the point that those kind of products might get stolen or they're quite small bottles often, aren't they? So they might get lost. So certainly that's really good feedback that I can take back, and we'll look at the policy on that. Cool.
Thanks so much, Ian. Thanks for being so adaptable and for your time and expertise. It's really
All right.
appreciated. And thanks
Brilliant.
everyone for joining. We will recirculate the documents that Ian's been referring to, and we will, when I share the recording as well, I will let you know what the best way to give any extra feedback, as well as what you've already asked tonight.
Cool. Thank you very much, guys. Nice meeting you all online. Hope you have a good evening. And well, see you all soon, hopefully. All right. Take care.
Thank you.